All right, let's jump right into one of the trickiest situations you're going to face, both in the clinic and on your board exams. A patient's platelet count is suddenly in free fall. It's a classic clinical puzzle that forces you to think fast and think smart. So, when the platelets just vanish, where do you even start? This right here is the million-dollar question we're tackling today. Is it the body attacking itself, a catastrophe of tiny clots, a weird reaction to a drug, or just total systemic chaos? Figuring this out is absolutely critical because the treatments are worlds apart and making the wrong call can be disastrous. Getting this right is how you're going to ace your exams and, way more importantly, save a life.
So here's our game plan. First, we're going to crack the code on what's going on. Then we'll march through the big four culprits: ITP, the autoimmune attacker; TMA, which is just microvascular mayhem; HIT, heparin's crazy paradox; and DIC, full-blown coagulation chaos. And you'll want to stick around, because at the end we'll put them all head-to-head in the final showdown.
First up is immune thrombocytopenia, or ITP. Now, if there's one thing you burn into your brain about ITP, it's this buzzword right here: isolated thrombocytopenia. What does that mean? It means this is purely a platelet problem. The red cells are fine, the white cells are fine. It's a diagnosis of exclusion, meaning you have to be sure nothing else is causing it. So what's actually happening under the hood? Well, the body's immune system has basically gone rogue. It's churning out these antibodies that latch on the platelets and scream, "Hey, destroy this," to the rest of the body. It's a classic case of friendly fire. Now, sometimes this just happens out of the blue. That's primary ITP. Other times, it's triggered by something else, like an infection. Think HIV or Hep C, or even another autoimmune disease. This right here is your classic exam vignette. You get a patient with those telltale petechia or purpura, those little pinpoint red dots or purple bruises. And the lab report comes back. The only thing that's off, the platelet count is in the gutter. Your first move always is to check a peripheral smear to make sure the platelets aren't just clumping together. And then you start screening for those secondary causes we just talked about. Okay, so how do we treat it? It's a pretty clear step-by-step approach. You know, if the patient isn't really bleeding and their count is above 30,000, you can actually just watch and wait. But if you need to act, first line is almost always corticosteroids to calm down that overactive immune system. If that doesn't work, or the case is really severe, then we climb the ladder to second-line therapies like TPO mimetics to boost platelet production, or even stronger immune drugs like rituximab.
All right, let's switch gears to our next bad actor: thrombotic microangiopathy, or TMA. This is a totally different animal. Here, the problem isn't just that platelets are being destroyed. The real issue is that tiny little clots are forming in the small blood vessels. These microthrombi are chewing up platelets and, get this, they're physically shredding red blood cells that try to squeeze by. And that brings us to our all-important buzzword, schistocytes.
Now, TMA has two main flavors you absolutely have to know cold for your exams: TTP and HUS. Nailing the difference is everything. So, TTP, you should be thinking of an adult patient, maybe with some weird neurologic symptoms like confusion. This is caused by a deficiency in an enzyme called ADAMTS13. Then there's HUS. The classic story here: a little kid gets a bad case of bloody diarrhea from E. coli, and a week later, their kidneys start to shut down. Totally different patient, totally different trigger.
Let me say it again because this is so important. If you see low platelets and signs of red blood cells being destroyed, you have to look at the peripheral smear. Finding these fragmented, busted up, helmet-shaped red blood cells called schistocytes is the absolute smoking gun for a TMA. You are literally looking at the wreckage from that microvascular mayhem.
Managing these is urgent, and it depends on the type. TTP is a straight-up medical emergency. You need to do plasma exchange immediately to get rid of those bad antibodies. For HUS, it's more about supportive care, fluids, maybe dialysis. And here is a massive, high-yield do-not-forget point. You do not give platelets. Giving platelets in TMA is like throwing gasoline on a fire. It just fuels more clot formation and can make things way, way worse.
And now for one of the biggest paradoxes in all of medicine: heparin-induced thrombocytopenia, or HIT. This is where a blood thinner, a drug designed to stop clots, does the exact opposite and triggers a massive body-wide clotting disaster. The buzzword? I like to call it the paradoxical clotter.
The number one clue for HIT is the timing. It's all about the timing. This doesn't happen on day one. The classic scenario is a patient in the hospital, they're on heparin, and then boom, about a week later, their platelet count is suddenly cut in half.
That 5 to 14-day window, you have to remember that for your test. It's a huge giveaway. This slide nails it. This is the core definition you need to know. It's that specific combo, the timing, 5 to 14 days after starting heparin, and the severity of the drop, at least a 50% decline from their baseline. When you see that, alarm bells should be ringing loud and clear in your head. So what do you do if you suspect HIT? You have to move fast. You do not wait for the lab test to come back. Step 1. Stop every single source of heparin. That includes heparin flushes and coated catheters. Step 2. Immediately switch them to a totally different kind of anticoagulant, like argatroban. This is a true life-saving intervention you have to do right away. Okay, our final stop. Disseminated intravascular coagulation, or DIC. This is the absolute ultimate meltdown of the body's clotting system. The body starts throwing tiny clots everywhere, and in the process, it uses up all of its platelets and all of its clotting factors. And the paradox here? That leads to massive, uncontrollable bleeding. It's the definition of chaos, clotting and bleeding all at the same time. The lab panel for DIC is unmistakable. It tells the whole tragic story. Platelets are low, fibrinogen is low, because they're all being used up to make clots. Your PT and APTT are prolonged because all the clotting factors are depleted too. And the D-dimer, it's going to be sky high, which shows that the body is frantically trying to break down all those clots. And that's the key differentiator from TMA, by the way. In DIC, your coagulation studies are prolonged. That is a huge clue. Now, super important point. DIC is never the primary diagnosis. It is always the result of some other massive insult to the body. The usual suspects? We're talking about overwhelming sepsis, major trauma or burns, some types of cancer, and big-time obstetric emergencies. Your real job is to figure out which one of these lit the fuse. So managing DIC is a two-front war. First, and most importantly, you have to go after the underlying cause like your life depends on it. Give antibiotics for sepsis, manage the trauma, deliver the baby. At the same time, you're playing defense. You're supporting the patient by replacing the blood products they've lost. Platelets, fibrinogen, clotting factors. But, and this is key, you only do that if they're actively bleeding or at a super high risk of bleeding. Phew! Okay, we've gone through the 4 horsemen of platelet destruction. Now for the final showdown. Let's boil all of this down into one high-yield table that puts it all together. This is your ultimate study guide for the boards. This slide is everything. You gotta know this cold. If you see only low platelets with a normal smear and normal coags, your brain should scream ITP. See low platelets plus those shredded schistocytes but normal coags? That's TMA territory. A history of heparin use with that classic 5 to 14-day drop? You better be thinking HIT. And finally, if everything is haywire, low platelets, prolonged coags, low fibrinogen, and a massive D-dimer, that is the signature of DIC. It's all about recognizing the pattern. Look, spotting these patterns isn't just about scoring points on a test. It's about being a sharp clinician who can make the right call when seconds count. So the real question is, now that you know what to look for, which one of these silent destroyers are you going to catch first? Thanks for joining me for this breakdown.